Well, happy Thursday, everyone, and thanks for joining. So my name is Ariel Medford. I'm a senior medical oncology fellow at the Mass General Cancer Center, and I'm really looking forward to chatting with everyone about current and then future applications of ctDNA assays with a focus on the Signatera MRD assay. So these are my disclosures, as well as the fact that while I work for MGH, I'm not speaking on behalf of MGH, and I'm speaking as an independent consultant. So objectives. So first, just talking about what cell-free DNA is and what circulating tumor DNA is. We'll talk about what tumor-informed sequencing is, why we use it, what makes it clinically significant, and then what questions are yet to be answered, and some exciting things to think about towards the future. So first, what is cell-free DNA? What is circulating tumor DNA? So broadly speaking, cell-free DNA is really just any sort of DNA independent of the cell that's been deposited within circulation. So while we think about it in oncology conferences in the context of cancer, you can have cell-free DNA deposited in the circulation from inflammation, from areas of tissue injury. When women are pregnant, you can detect neonatal cell-free DNA. And so circulating tumor DNA is specifically tumor DNA within the cell-free DNA content. Important to know, and this will be really helpful when we're talking about this assay, is the fact that it has a very short half-life, at most 2 hours. Again, cell turnover, so proliferation and apoptosis can contribute to the cfDNA content. And as I mentioned, it's not exclusively cancer, so inflammation, autoimmune conditions, exercise, and then of course when we give cytotoxic therapy, we can induce tissue injury and again, increase cell-free DNA content. So this is how I like to think about the cadence of circulating tumor DNA. So now we're talking specifically about ctDNA in the cell-free DNA content. And so if we think about the beginning of a patient's course with primary breast cancer, up front they undergo surgery and other treatments, whether that's chemotherapy, radiation, and then certainly surgery being a mainstay of therapy. And usually the ctDNA content should drop to 0 because, as we mentioned, ctDNA has a half-life less than 2 hours. You should not have residual ctDNA if there's no residual tumor within the circulation. And as we know that in order to reduce recurrence risks, we'll give adjuvant therapy to minimize that risk. And ostensibly, if there's no tumor content, there should not be circulating tumor DNA, and so it should stay at 0. Now, unfortunately, almost a third of patients do experience relapse, and so thinking about the ctDNA content, often it does start increasing prior to clinical recurrence. And so once clinical recurrence has occurred, because the tumor content is larger, we would anticipate the ctDNA content to be larger and larger than it was in the primary most often. And then we treat. And when you treat, we have data to suggest that ctDNA often decreases in response to treatment, and it should return, often it won't go back to 0, but it does get low. And then unfortunately, the other thing we know is that cancers develop resistance. And so at that point, one early evidence of evolving resistance and progression is a new increase in ctDNA. And then clinical progression succeeds that. It tends to happen after the initial ctDNA increase. And then again, the cycle continues of continuing treatment. So here we'll talk then kind of about a more nuanced concept that's only been detectable because of more sensitive assays. And so historically in the metastatic setting, we've been able to detect these cadences more sensitively because we have a decent amount of circulating tumor content. But now with really sensitive assays in the early setting, say a patient undergoes treatment and curative therapies, but the ctDNA content never goes to 0. Again, kind of reiterating this point, ctDNA should not be in the system if the cancer is gone. And so this we would call residual molecular disease. So you have no evidence that there's cancer, the tissue has been taken out, but if you still have ctDNA, we would call that a residual molecular disease. Now, another thing that can happen if you look at the dotted blue line is, let's see if I've got the dotted blue line, is the content can go to 0, and then if we have serial sampling, you can start noticing positivity from there. So now the content starts increasing, and that again would precede, and we'll talk about the evidence behind that, the clinical evidence of relapse, and that's a molecular recurrence. So we have residual molecular disease and we have recurrent molecular disease, and coupling all those together, we'll call that minimal residual disease, MRD. So these are the two phenomena we're talking about when we're talking about MRD. So what's tumor-informed sequencing, and why would we use it? So starting with what is it? So the Signatera assay being a tumor-informed assay that's now in use in several clinical trials as well and has been validated in ways that we'll discuss. So in historic ctDNA assays in the metastatic setting that are more in the targeted context, you don't really know what you're looking for, but you have enough ctDNA content to identify something well known, PIK3CA, ESR1, you can use these targeted panels. But in the early setting, the ctDNA content can be below 0.1 percent allele frequency or allele fraction, which is very hard to detect because you're effectively testing multiple hypotheses at once, not really knowing what you're looking for. So how do you increase sensitivity? You can do targeted sequencing of the primary tissue and then make primers exclusively to mutations that you know that the cancer has. And so, the Signatera assay designs these primers for the top 16 clonal mutations and creates this multiplex PCR assay. So now we know what we're looking for are tumor-related because we got them from initially sequencing the tumor. And so then what happens is once a patient is in that early disease setting, you are doing blood testing looking for evidence of minimal residual disease based on these personalized amplicons that we know were designed based around the genomic makeup of the tumor itself. And so in terms of target selection, so there are multiple somatic mutations, there's whole exome sequencing of numerous genes, and first they base clonal mutations, and so you're looking at the overall variant allele fraction within the tissue itself, and so you're looking for a clonal mutation. And then there's some nuances with what's designable, and so something that can fit well in multiplexing, because we're not doing individual PCR tests afterwards, it's a single multiplex assay. And then detectable mutations with a low background error rate because you don't want to have false positives in this setting. So that's the principle behind that. And it could look something like this. You find any number here, we have 25 different variants, and then the 16 that are selected for the personalized assay moving forward. And then we have an image here of a fingerprint because it's effectively very personal to the tumor itself, so that the patient, it's been designed around the patient assay itself. So why? So why would we want to do a personalized and tumor-informed approach? And so thinking of the actual MRD assay requirements, it needs to have a very small amount of ctDNA. We've talked about how the concept of ctDNA was developed in the metastatic setting, but only recently could be moved to the early disease setting because we needed such sensitive assays because the allele fraction is so low. And so that's where increasing the number of variants, because you don't have to find 16 variants for something to be MRD positive, you need to find a known variant, and so you're expanding the breadth of variants that you're looking for, and that initial identification was under ultra-deep sequencing of that primary tumor. It's very specific, and we'll show some data behind that. And one way that's done is germline mutations and then clonal hematopoiesis of indeterminate potential chips, so clonal mutations unrelated to the cancer. The way that those are taken out is that when the sample is first collected, the white blood cells in the Buffy coat undergo sequencing to identify germline mutations and chip mutations, and so those would not be part of the personalized amplicon. So now you know I really am looking for tumor DNA, and these chip and germline are tough confounders of blood-based assays in general because they're not exclusive they're in circulation. Where did I click? There we go. And then thinking about the actual disease burden, and so it's quantifiable. The metrics that are reported out are mean tumor molecules per milliliter. That's the MTM. You'll see that in the graphs moving forward, and we'll talk about those. And again, keeping in mind that we're still accessing the benefit of why liquid biopsy has become so popular. When you're sampling from a single tissue site, obviously in the case of early disease, after it's been taken out, you don't have a tissue site to sample, but also your blood's a repository for DNA deposited from throughout the body, and so it's kind of a surveillance of everything that's in circulation. So thinking about different utilities of something that can detect such sensitive mutations, we'll talk about the data from I-SPY involving the response to neoadjuvant therapy, which is very interesting, and kind of thinking about the future aspect, which is kind of in our mind's eye at the end. Responses to adjuvant therapy. monitoring for recurrence, so those two very distinct MRD scenarios, and then theoretically treatment response in the advanced setting. We won't talk about that as much because the uniqueness of this is how applicable it is in the early disease setting. So first, let's think about what are the limitations of what we could do now. So we use surrogates at single points in time to identify patients' risk. And so if a patient, particularly our patients with HER2 positive and triple negative breast cancer, if they receive neoadjuvant therapy, we really hang a lot on pathologic complete response because we know that that portends a good prognosis. But what if they have residual disease? Really, right now, patients are going to be getting escalated therapy because we know that that's a higher risk of recurrence. But it's a single point in time, and so we're really assessing an overall risk of recurrence without continuous monitoring subsequently, and are having to make estimations based on data that we have from PCR, from pathologic complete response. Tumor markers, so we do have blood-based biomarkers, but they're not sensitive. They definitely have a poor positive predictive value for recurrence, and are not used in practice for this reason. So they're just not applicable to the patient population, the questions we would want to answer. And then imaging tools, as we know, it's not standard of care to do any imaging besides breast MRI or mammography in patients that have residual breast tissue. But otherwise, there's no utility in the image. There has been no improved outcomes based on surveillance imaging, so it's not recommended unless a patient reports a symptom. So then the clinical significance. So this is, we'll go over some of the data we know, which is pretty exciting. So first, the response to neoadjuvant therapy. And so we'll talk about the I-SPY 2 platform, which I think has really shaped a lot of our thinking around this topic. So the I-SPY 2 trial design, so that's a neoadjuvant design, and it's the adaptive clinical trial platform study. I'll show a schematic, but effectively using targeted therapies, a number of different targeted therapies, and where study drugs can come and leave, and it's a very personalized approach to patient care. And in terms of the ctDNA objectives, part of the ctDNA component that's now being reported is how can we use the ctDNA response in the neoadjuvant setting as a biomarker, and then identify prognostic value accordingly. And I think the results are very interesting, especially thinking about future studies. So I-SPY, baseline ctDNA, so we'll call that T0, ctDNA is taken, and neoadjuvantly patients first receive 12 weekly cycles along with an investigational matched study drug. So if a patient has a targetable alteration, they would get the matched study drug in addition to the paclitaxel. At that time point, they would have a ctDNA test again, so we'll call that T1. After completion of those 12 weeks, they get another testing, that's T2, and then they get the 4 cycles of AC, and then subsequently T3 is the final sample prior to surgery. And so then, pathologic complete response, no pathologic complete response. And the objective was the ability to determine the ctDNA's role as a biomarker, and you can see there have been several reportouts of it, which we'll hone in on starting in 2020 and most recently in AACR of this year. So early ctDNA clearance, predictive of survival benefit. So this was really important. So at T1, so remember that was at the start of the paclitaxel plus or minus the investigational study drug. If a patient was ctDNA negative versus ctDNA positive, that already starts stratifying patients based on recurrence risk, a hazard ratio of 4.3, and you can see quite a significant p-value. And these were patients with high-risk stage 2-3 breast cancer that are shown here, who got neoadjuvant paclitaxel plus or minus pembrolizumab. So this is an immunotherapy group. And importantly, if they cleared the ctDNA, they had a significantly reduced risk, as we talked about with that hazard ratio. So then that question we talked about before, so we use pathologic complete response as a surrogate. We know that if you have a PCR, we know that's a great prognosis, but once someone has a positive residual disease, that's kind of all lumped together as a poor prognostic, and yet we can use ctDNA to stratify. And this is very interesting. So here's the HR positive, HER2 negative group, and then on the right is the triple negative breast cancer. And this is very interesting. So again, these are high risk stage 2-3. These are the ones that got IO. And you can see that if a patient in the light blue line are the patients that had pathologic complete response, all of those patients ended up being ctDNA negative. The blue line are the patients that did not have a pathologic complete response and were ctDNA positive. And so we know that that's associated with a poor response independent of ctDNA. But adding the ctDNA positivity, very poor recurrence risk. But what's interesting is that light green line, because that is patients who did not have a pathologic complete response but did have negative ctDNA, and these were not significant hazard ratios. The confidence interval crosses 1. And so if they cleared their, regardless of PCR status, the persistent T3 was associated with a shorter distant recurrence-free survival, and then compared to ctDNA negativity, there's this unique subset who are who did not have a pathologic complete response but did have ctDNA clearance that have much improved outcomes, so starting to hint towards this other biomarker component. And then here you can see some graphs based on the patients that were treated with an AKT inhibitor as part of this, but patients that had early ctDNA clearance. So in this study, 73% of patients had positive ctDNA at baseline, and then by T1, that number had dropped down to roughly 43%. By T2, that number drops down to 14%, and then you just get under 10%, so 7 remaining patients at T3. And if patients do not clear their ctDNA content, we know that that is associated with quite a high risk of recurrence. So then thinking in another context of the neoadjuvant setting, thinking of other surrogates we use like radiography. So the Bellini trial was immunotherapy in early triple-negative breast cancer, testing nivolumab plus or minus ipilimumab. And in this case, it was 30 patients with triple-negative breast cancer. They underwent ctDNA testing, had an MRI biopsy, got 4 weeks of either nivolumab or nivolumab plus ipilimumab, and then 4 weeks later underwent ctDNA MRI biopsy again, and then they received standard of care neoadjuvant therapy. And what's interesting here is when you look, there are 7 patients that had a partial response based on MRI, so the patients on the right. And all of them had some component of either no ctDNA at baseline, clearance, or at least a reduction. And if patients had no clearance or reduction, none of those patients reached partial response, and most of them had increased tumor size, whether or not it qualified as progressive disease. Now, I will say with the caveat that you can see that there are those light blue patients that did have the partial response that had no ctDNA at baseline, but also you have the patients that had growth. And so the no ctDNA at baseline, I will point out, is something just of interest as well. But if we're to hone in on the patients that had MRI response and then look at their ctDNA profile, it's hypothesis generating, and I think as we move forward, something to really think about contextually. And then early response indicators, so again, thinking about imaging-based assessments of response, molecular assessments of response, and we certainly know in clinic we do physical exam-based assessments of response. And so knowing that early dynamics of ctDNA, you can see that the patients that had progressive disease had increases in their ctDNA, and patients with all the patients that had partial responses had some degree of decrease in their ctDNA. And then there were certainly patients that had stable disease that went both ways. And so again, hypothesis generating, things to think about as we figure out the dynamics of ctDNA in this context. Okay, so that was neoadjuvant therapy. Now, thinking about our responses to adjuvant therapy and monitoring for recurrence, so the MRD space. And so here we talk about EBLIS, which really is a fundamental study for us to think about what we can do, what we can glean from early identification of ctDNA. So this is the exploratory breast lead interval study. This is the longest ctDNA study follow-up to date, and the primary objective was to determine the lead time of ctDNA positivity prior to clinical recurrence. And so patients that, in whom you would, how early can you detect ctDNA prior to what's already standard of care, the regular screening intervals that we have. So this has been updated multiple times over, but at this point it was 188 women with high risk stage 2 to 3 breast cancer of all subtypes. there was 156 patient samples that were analyzed with the Signatera assay. And then you can see this breakdown that the majority were HR positive, HER2 negative, but we also had triple positive breast cancer, triple negative, and 8 HER2 positive patients as well. And so thinking, I'll just kind of pull these up automatically because they're really impressive. So the relapse-free survival and the overall survival. So ctDNA positivity is in the green, and then in the blue is negative ctDNA detection. So for relapse-free survival, it's a hazard ratio of 30, and an overall survival hazard ratio of 19, so very convincing if you are ctDNA positive. And again, let's go back and just think about the science and think about the biology. If you have a very specific assay and you're actually detecting ctDNA, it should not be in circulation unless there is residual or recurrent cancer, and so that's kind of your first herald. But now we actually have clinical data to say, yes, it proceeds. And so then the question, by how much? So again, ctDNA, worse recurrence-free and overall survival. It was detected in 30 out of 34 patients, so an 88% sensitivity. And importantly, 10.5 months lead time over radiographic recurrence, and it went as far as 38 months. So there were some patients that over 3 years prior to clinical recurrence were having ctDNA positivity. You can see this broken down by the HR positive, HER2 negative, which was the largest group. The HER2 positive, we talked about, that was a smaller group of only 8 patients, but 15.7 months, and triple negative, 8 months, and then the triple positive, a median of 6 months. So interesting, just thinking that we know that from a blood assay we can assess this, but again, thinking forward, okay, kind of in our mind's eye, what are we going to do with that information? That's very anxiety-provoking to have that type of diagnosis, so what do we do? And that really brings us to the what questions are yet to be answered, because this is very important preliminary data, but now we need to figure out how to improve patient care. Since unfortunately knowing this at this point, knowing there's going to be a recurrence, you can imagine, I think, would be quite a source of anxiety. However, we have clinical trials ongoing, and I think thinking towards the future, what we can do for patients. And so kind of thinking here of this recurrence-free interval, there are really 2 fundamental questions. I think the one that's ongoing right now is this in the light blue in the bottom. So patients that have ctDNA positivity, can we escalate care? Can we either cure them, which certainly is goal, or at least induce a deep remission? And then in the purple, I think a little further in the future, but something that I think is a goal that we all want, is we'd love to de-escalate care. We know that we're over-treating many patients, and the goal is to cure as many patients as possible, but can we de-escalate therapy, which I think would be incredible for our patients. So again, kind of summarizing that state, detectable ctDNA after surgery or on adjuvant therapy, strong association that you've got a risk of recurrence. Can MRD be used to determine, to tailor adjuvant treatment in both the positive and escalation and in the negative of de-escalation? And so this is just an example to kind of think about, if all of us imagine a patient coming into clinic who's had a ctDNA assay, patient with a triple negative breast cancer, has received adjuvant chemotherapy, neoadjuvant chemotherapy, has undergone lumpectomy, had residual disease, and so is on standard of care, received radiation, on capecitabine, and had an initial Signatera assay that at 24 months was positive. Now, one question I think is very reasonable to come up with is, if you're detecting ctDNA, because we don't scan patients, do patients have radiographic metastatic disease that we're just detecting molecularly because we're not scanning? Sometimes yes, so some studies have certainly seen that's the case, but not all patients, and so really honing in on that subtype. So if a patient had cause for CT for whatever reason and has negative CT, but then on this second assay, again, something prompts a CT scan, now they have biopsy-proven triple-negative breast cancer that's metastatic, and then in this example case, we put a patient on standard of care Keynote 355. Does that benefit the patient that we found it sooner, or is there something else that we can do? Because I think this is a challenging scenario. We don't know that molecular identification earlier and starting therapy on metastatic treatment is better. I think the other question is, what about that first positive ctDNA? Is there something we could have done at that point, which is what several clinical trials are trying to ask now. And so that's this, can adjuvant intervention change the risk or the time of recurrence? And so I'll kind of go back to the schematic we talked about before. So we're thinking of, in this first scenario, so a patient doesn't clear after neoadjuvant therapy, those I-SPY 2 patients who T3 were still positive. Can you add additional adjuvant therapy and change the time course of this? Obviously, all of us want to move towards cure, but even can we push a patient into a deep remission and just prolong their disease-free time before they're managing a metastatic breast cancer? And then similarly, if we're doing serial testing and a patient is negative, negative, positive, or like in this example patient we're thinking of as negative and positive, at that positive, or sorry, no, not that patient, but thinking in general, this is something we've seen in our studies too, who are negative and turn positive, so now we have molecular recurrence. In that case, similarly, can we add additional adjuvant therapy and again, push them at least into a deep remission? So that's what several clinical trials are trying to answer. So there are a couple. So one is the part 2 of the LEADER trial. That's for patients with estrogen receptor positive, HER2 negative breast cancer who've already been on endocrine therapy after surgery. Because again, we want patients who've been on standard of care and still are ctDNA positive. How can we improve their outcomes? So initially, this was a randomized trial. Patients were randomized to endocrine therapy or endocrine therapy plus ribociclib, with monarchE coming out and adjuvant therapy being added in that context of high risk from clinical features. This is now a single-arm study with endocrine therapy with ribociclib, and the primary endpoint is going to be ctDNA clearance, with secondary endpoints being overall patient outcomes. And then the DARE trial is a similar study, and both of these are using the Signatera platform. So the DARE study is a stage 2-3, again, HR positive, HER2 negative, high-risk patients who are on adjuvant endocrine therapy. They test positive, and as far as I know, this one is still randomized, but the same principle on if you add palbociclib in this case, can you change outcomes? And then in this case, the primary endpoint is disease-free survival.